Excellencies, colleagues, ladies and gentlemen, all friends here. Let's get started into this afternoon session. And I think it will be very exciting. So we all had prepared some notes, but we have just agreed that we won't use them, including myself, and that we try to engage in a real dialogue. And we will start a little bit with an introduction, how the ideas of the SDGs, and I'll say a word about that in a minute, actually have an impact very concretely and practically on the work that we are doing. And this is a real cross-section of different sectors. With one exception, we're very sorry that one of the panelists dropped out, Her Excellency Toyin Ojora Saraki, who is an African woman. She leads an NGO. She works with women and girls in particular in Wellbeing. She could not come. We are very sorry about that because it would have been a very important addition. But here we have colleagues from the private sector, from the public sector, from the financing institution, which really covers a wide spectrum of the work that we have to engage in the SDGs, which is a completely new concept compared to the MDGs. I don't want to go into much detail because all of that you know. But it does pose real challenges how we work together. And I think we would like to start with that for a couple of minutes or 30 minutes or so, and then really go in a much more interactive session where we would like to provoke ourselves to come up with concrete solutions or questions that we want to take forward. And obviously, we would also like your reactions to that. Now, let me very briefly introduce the panel, and I don't want to take much time because we could spend the whole 1.5 hours to, dwell on the great things that all these people have done. We won't do that, but let me just go through the list very briefly. Let me start with Caroline Ryan. She serves as the Vice President of Corporate Responsibility and Reputation at Pfizer and as the President of the Pfizer Foundation. In that role, she oversees Pfizer's corporate responsibility function, including stakeholder engagement, corporate responsibility reporting, and designing social investment strategies. We couldn't have had a better representative from the private sector. We have Peter Sands, who is the Executive Director of the Global Fund. He started that job less than a year ago, March, half a year ago, and already has done a lot of great things there. Took over an organization that has been known for innovation, and we will test whether that has continued in the challenges of the SDGs. Then we have Trevor Mundel, the president of Global Health Division at the Melinda Gates Foundation. He's known as a real star in product development, and we will have to get back to that. Even in this new role that he has now, I think he is still pushing and leading startup organizations, but he also has said something, and I get the quote wrong, but you have studied philosophy and you felt that that would be a good counterbalance to something that you are doing on your day-to-day job to also get it right. But you can talk to that yourself much better. Finally, my colleague Mariangela Simao. She is the Assistant Director General at the World Health Organization with responsibilities for drug access, vaccines, and pharmaceuticals. And she also leads the program of pre-qualification in the World Health Organization, which, of course, access to medicines obviously is one of the cornerstones in universal health coverage, a topic that we will have to discuss as we think about delivering on the SDGs. Now, let's start. As I mentioned, the SDGs can only work if we understand development as an interconnected web of economic development, social development, environmental development, and all of these things that have to come together, partnerships. Now, can we have the first round of discussion where you really talk from your own perspectives, how the SDG framework has actually changed the way you do business in your respective roles, which clearly must have changed. Caroline, why don't we start with you?
Sure. First, I just want to thank you for the opportunity. Would you like me to sit or stand?
As you feel.
We were joking that the chairs are so comfortable, we're going to slide back for a nice nap. But first, I just want to say thank you for the opportunity to be on this panel. And I think most importantly for Pfizer Germany and for Pfizer to be able to partner with the World Health Summit on this 10th anniversary. So that my back is not to my fellow panel members. And At Pfizer, we believe, and if you don't know us, we discover, develop, and bring to market medicines and vaccines that help people live longer and healthier lives. And in that context, we believe that when we deliver for our patients, we deliver for society, and we deliver for our shareholders and investors. And in that spirit, when we met the SDGs, we think of the SDGs as a fantastic roadmap for how the private sector and the pharmaceutical companies can engage in a shared and common dialogue. That might surprise some of you, but we have really embraced that at Pfizer, in part because we are such close neighbors to the UN. Our world headquarters are on the corner of 42nd and 2nd. And one of our first steps to embrace the SDGs was to educate our 90,000 colleagues on the importance of this work, how they can personally engage, and how the company can engage in this activity. We took our windows around our world headquarters and wrapped them with information about the SDGs in partnership with the UN Foundation. And that really was that effort to say these matter. They matter to us personally, they matter to us individually, and they matter to us as a company. In that way, we are also focusing on reporting. So looking at how we make our investments, and we're deliberate about saying investments into the communities that need our vaccines and medicines, and measuring that impact against the global framework. And all of our colleagues at headquarters are certainly very familiar with this. Our executive leadership team has adopted and understood the North Star of Goal 3, which is good health and well-being, and how we'll advance that. Now, maybe if I could give one nod before I pass the microphone over to Goal 17, which is where you hear a lot of the private sector come in to play. I think we'll get into this in the panel discussion, but partnerships are going to be key. And for many of us in this room who've worked their entire careers in health and advancing health for under-resourced communities, we throw around partnership very easily. But what does that really mean? And we're going to get into that on this panel. What does it mean for a corporation, for a private sector, for the pharmaceutical industry? And I want to reference two quick programs and learnings that we've had over the years that we're applying to how we think about partnership going forward. You may have heard our Chief Operating Officer speak at the Keynote earlier this week. He referenced the International Trachoma Initiative. And the reason we talk about this so much is because that was not an easy project to launch back in 1998. It has not been an easy project to sustain. And a couple of the learnings that we've had as we've made our way through that, I like to say a merry band of deeply committed partners, more than 100 strong, is that it takes more than a medicine, which we all know. It takes a comprehensive public health strategy to drive impact. We also had to come to the table with some level of skepticism, literally and figuratively speaking different languages, putting that aside and trying to build trust one step at a time as we took on really profound issues around driving toward a world free from trachoma. I think we've taken those learnings to heart, and we're prepared to engage very productively in a go-forward framework around what partnership means. The second one is around our entrepreneurship program. Very different approach for Pfizer and the Pfizer Foundation. Small, nonprofit organizations and for-profit organizations that are bringing technology to bear to expand primary healthcare services for some of the most vulnerable populations. In that spirit, we had to change how we think about funding and bringing our capital. We're marrying not only our financial support, but the support of our Pfizer expertise through our colleagues to these organizations. And we've learned to be more flexible and nimble and have much more honest conversations with our partners about what's working and what's not, so we can flex and adapt to their needs. So maybe that'll start us off in a perspective from the private sector as we get into a rich discussion of how we can advance the SDGs. Thank you.
Thank you very much, Caroline. A couple of keywords which you should keep in mind as we go into the more interactive part is the trust and the partnerships that you, and the honesty. I think this is really a topic that we would like to reflect on this panel as well. Peter, you're leading the major health financing organization, excluding Gates from that in a little bit because you have a very different role to play, but you have been created, your organization has been created for that purpose, but it has been created for the purpose to tackle 3 diseases, which are major public health diseases, but as we see, today's challenges may actually have been shifting to non-communicable diseases, to systems building. What does this mean for your work on a day-to-day basis, very pragmatically?
Right. Well, to start with, I'm very grateful to the authors of the SDGs because as somebody who is relatively new to the role and not from the public health world, I was an economist and banker, it's provided me with a really succinct way of describing what I do. Because people say, well, what is this new job you're doing? And I say, well, you know, I look at one of the indicators of SDG 3, end the epidemics of AIDS, TB, and malaria by 2030. That's my job description. Really very simple. So I'm very appreciative of that. Couple of points, though, picking up on your question. One is, there is an important shift here. When the Global Fund was first created, it was created to save lives, to stop the explosion of deaths, primarily around HIV, but also TB and malaria. And now we have shifted the goal. We still want to save lives, absolutely, but we also want to end the epidemics. And that is an important strategic shift in the way we think about priorities and programming. But the third point is the broader issue, as you raised, which is we are now very much more alert to the fact that we are part of delivering on the broader achievement of SDG 3 and indeed the broader achievement of the Sustainable Development Goals as a whole. I get a lot of, aren't you a vertical disease-focused fund, and isn't that in opposition to doing horizontal systems building? I have to say, my heart sinks every time I hear this. There's a sort of debate about theological schisms type thing going on there in the enthusiasm of people in the global health world to sort of endlessly debate vertical versus horizontal. I mean, my view coming into it relatively new is I'm not aware of any country that has managed to end the epidemics of either AIDS, TB, and malaria without a good health system. So we will only achieve our mandate if we help build good health systems. And I'm also not aware of any health system that you could describe as being good, which hasn't got a good grip in protecting its people from AIDS, TB, and malaria. So from both perspectives, we need both. And the reality is the Global Fund is investing hugely in health systems, whether it's community health workers in Ethiopia, it's community health insurance schemes in Rwanda, supply chain in Tanzania, all sorts of different aspects. We spend about $1 billion a year, which makes us the largest provider of, among the multilaterals, of grants for health system development. Could we do it better? Absolutely. I'm sure there are things we can be doing better. And indeed, I think this is what is powerful about the SDGs, is that they act as a challenge to all of us to say, how do we work to achieve the broader goals, both in the things that we're doing on our own, but also in the way that we're working with WHO, the way we're working with Gavi, with the World Bank, and with other partners, so that we're both delivering on our specific mandate, but also pushing forward the broader agenda.
Great. Thank you, Peter. I think, Mariangela, I want to turn to you because I just realized that you have like 3 hardcore private sector partners on this panel. So we need to give you the word and maybe a little bit more often. Anyway, see, Peter was mentioning, and the hardcore is not at all negative, excuse me, but don't misunderstand me. So, but Mariangela, you were kind of just picking up on what Peter has said. This almost religious ideological discussion of horizontal versus vertical, that is, of course, something that I have to say our organization, I'm not here as part of WHO, I'm the moderator, so she has to carry this forward. For the World Health Organization, what does that mean? How do we work? How does WHO work in this horizontal versus vertical way? What's the challenges here?
I'm going to get up because there are many challenges, but this is such a comfortable chair, you can't imagine. I would suggest that anybody who wants to get a nice nap in the intervals, come here and I have a disclaimer before I respond to the challenges that Bernhard just raised. Because I'm Brazilian, so nobody's allowed to talk about politics with me today, please. Okay. But I've been a Brazilian my entire life, and I'm in the UN 8 years only. Okay, so it's never, you can never shed all your spots, right? So a lot of the country work, I worked at country level in the national health system for 30 years, which more or less gives my age already, right? But I think one of the challenges we have with WHO and even with the SDGs, we're just having a lunch discussion with a smaller group of people, is that we can have the best framework in the world, but if we collectively don't make it work, it will lead us nowhere. You know, it's just dead letters in the end. And we truly believe that the SDG framework is the right framework at the right time. You know, and how central health is to the SDGs framework. The centrality of health, it's just, you know, when you look at it, you know, out of the 17 goals, we have 14 that have health-related targets. So this is recognized first time in a way that the MDGs didn't bring to the table. So our challenge is even bigger because we will never be able to respond either as an organization by ourselves or as a collective if you don't think of health throughout the lifetime. And I'm taking my time now that I'm standing up. No, but I was sharing with colleagues a reflection that health is the only system that has to cater for people before they are born until after they die. You know, because the regulations for burial, cremations are health regulations. So the complexity of health is expressed in the SDGs. Now, what is WHO role on this? I think we have a global program of work. It's a response to the SDGs. You know, it's how WHO is getting organized. It was approved by member states now in May. How do we get organized to actually help countries have positive health outcomes, impact related? So this is very much this discussion now on the SDGs, and it's at the core of what WHO is doing with the global program of work, refocusing the attention and the activities to what will achieve most results at country level. I think that's not an easy process because many of these issues are of a political nature and less of a technical capacity. We have a lot of technical capacity. We need to do better negotiations politically to achieve better health outcomes. Thank you.
Thank you, Mariangela. Trevor, you have been working for the Gates Foundation for quite a number of years. So you have witnessed and supported the move from the MDGs to the SDGs. Now you are known for being a very targeted person, no bullshit person, if I may say so. What does this mean for you in your daily work and for the Gates Foundation, for the organization that gives so much money for the global good?
Thank you, Bernhard, and it's a great pleasure to be here. As you indicate, we worked very well with the Millennium Development Goals, and they had a certain simplicity to them, and we felt there was certainly an agenda which had not yet been reached with those goals. The SDGs, I think, present another great opportunity because they have tremendous endorsement from the wide community that actually developed them. But we have felt that there's a need for a roadmap, certainly for our work, which focuses on part of those goals. Now, you mentioned the product development and our focus on that, which really is SDG 3. And we have this initiative. We had an event last night called the Goalkeepers event, which recreated an event we've been having at the United Nations General Assembly for the last 2 years now, which is essentially pulling out 17 aspects of the SDGs, 18 aspects of the SDGs actually, and really measuring them in a certain way so that we can track progress. That's the intention of Goalkeepers in some ways. How are we doing against these SDG goals? So on the SDG 3, you might say, well, yes, your Goalkeepers and your forecasting where we are, it would focus because of the products that you're trying, the new tools you're trying to work on, SDG 3. But I'm not going to talk about that right now. Because out of the 18 tracking points that we have in the Goalkeepers event, 12 are around SDG 3, and the other 6 are not. And it's the other 6 which I think are more interesting, because without those other 6, and there are arguably more than them, we very much understand, I think everybody has a similar view, that products alone are not going to do this. So if I just quickly run through the other ones that we have a focus on, which surround the product development work. Firstly, it's poverty and alleviation of poverty. We know that TB is a disease of poverty. When poverty vanishes, TB vanishes. New York City, 100 years ago, slightly more than that, had a TB epidemic, which is very similar to the epidemic around Cape Town and the Western Cape in South Africa, of the same dimensions in terms of numbers of people getting infections. And that vanished before there were drug therapies for TB. Gender equality. We understand that the nexus of improved maternal, neonatal, infant health is really addressing the role of women and girls in society. And without addressing that inequality, whatever we can do in terms of tools and the like is not going to have the same impact. Education. Do people understand the opportunities they have in health? At that level, in terms of people who need health tools, healthcare workers as well need to have a certain educational background to be able to deliver these tools, to perceive the risk that one has in certain behaviors. Education is absolutely part of the mixture over here. Agriculture and the aspects of nutrition, inseparable, the microbiome and its impacts on disease. We're just beginning to appreciate that. Financial services. We know that people who have restricted incomes often have a dramatic descent in their ability to survive and their resilience based on health issues. So you develop TB needing treatment, and then suddenly your small amount of savings may be gone. So without access to financial instruments, how are you going to be able to resilient to these health impacts that occur and not drop into deep poverty every time, which is only going to exacerbate things? Water, sanitation, hygiene. Why should we be working on a cholera vaccine, typhoid vaccine, other enteric vaccines that we have? Are they going to be impactful in a setting where sanitation is in the state that it's in? That needs to be actually a joint effort between those extra SDG 3s and the SDG 3s.
Great. I want to call you a little bit on, and I think actually all the panelists on, you mentioned this Goalkeeper report, which I think is a brilliant piece of communication, as the Gates Foundation does many things very well. One of the things when I read this with increasing excitement, but then I came to these beautiful charts where you map, where we would get if we would keep in the current trajectory, and what we would have to do to actually get us to the goal. What's the gap? And I want to just put this out, and I really recommend that you all read this report. It's very nice, and also the efforts that you're doing. But one of the things I saw is that in pretty much every single, with very few exceptions, we are nowhere close to reaching the SDGs. Now that's the challenge, why we're sitting here today, isn't it? And I think the next round maybe of discussions, and then I would really want to start also you guys talking to each other, because I know from our pre-discussion, you have many questions to each other. But maybe a very short thought. Let's be short and concise. Now, what is it, the one thing that we have to do differently to actually change the trajectory that we have right now? Caroline, you want to start?
So I think probably from the perspective of the private sector, I would say two things. One is move with more urgency. And I think it's easy for us to say that we are moving with urgency because we gather here, we gather at other settings, and we talk through these issues. But honestly, I don't think there's enough urgency. And I think that applies to governments, it applies to the private sector, it applies to funders, multilateral organizations across the board. Because it can be easy to be caught up in the complexity. There's a simplicity to the SDGs and there's a complexity in terms of how we measure impact. So I think that it's easy to sometimes get caught in that very deep detail and forget the urgent need to ensure that the world is behind us in taking these issues on, one. And two, I think that we've got, and this gets to the broader discussion around how we think about partnerships, each of us brings something different to the table. And in the past, I think we spend a lot of time negotiating that instead of getting on with the work at hand. And my sense is that to accelerate progress, that means just figure it out, right? And that sounds very simple, but figuring out how to work productively, which is happening with the WHO from a private industry's perspective, working with our industry associations like IFPMA, working with the Gates Foundation. It gets complicated, right? And so if we can kind of keep our eyes on that prize and try to do our part to unmask or unhinge that bureaucracy that sometimes gets in the way, or the points of view, I think that'll help us move with more urgency, because we're not going to get there if we don't.
Two things. You said, one, we have to act with a proper sense of urgency, but you also said it gets complicated. So that is always an easy way out, isn't it? It's too complicated. Mariangela, you're working in a very complicated organization, sitting next to the private sector. What's your take on this?
I've been in the organization now for 11 months and a half, so it will be 1 year anniversary soon. But I think one of what needs to change, we need to ensure there is an environment where the right policies are the easier policies to be adopted by country. You know, I think we international organizations, sometimes we make the things so complex and so difficult to implement, you know, that people, I was a policymaker many years, that it makes it very hard to make the right decision. You know, so the hard decisions need to be easy decisions to make, because they are easy to implement. I think that's my main issue.
Can you give us an example? What's a hard decision that's an easy decision?
For example, the access to medicines decision, for example, right? It's not based on technical issues. It's a political decision, right? Because you may have the products, the products that are safe, that are available. Maybe they are not affordable. So you need to have a good support. The country needs to have good support from WHO and from international organizations to be able to face the issue of ensuring that access is possible. And I think HIV taught us that. You know, because when the world created the generic competition, where you had the environment where civil society was on board and nothing for us without us, kind of thing, and pushed for the right policies to be put in place. I think that's a very concrete example. And the international organizations need to respond.
Trevor, I want to come back to you for the simple reason, I think, Mariangela, thank you. I think we tend to forget too quickly that not too long ago, the world was not ready to even discuss and think about whether it's appropriate that people in the global south and Africa should be offered ARVs. It's not very long ago. I was part of that struggle. At that point in time, I remember a discussion, because it was a question of price, and then all kinds of, you know, like the complexities were used. It's too complicated. They don't know how to take the drugs, and it was complicated at that point in time. But there were many excuses. But at the end of the day, it was the sheer cost of the drugs. So I had a discussion with Bill Gates at that point in time, and I never forget that. He says, "Why don't we just buy the patent?" Now here I was as a public health worker. I couldn't even imagine that somebody just puts billions of dollars on the table to say, I own this thing and I do whatever I want to do with that. Is that how you still work in the foundation?
Well, we do buy patents, and we do make investments in companies that have patents. Generally, I think we work typically in a more collaborative way with some of the companies, in the sense that if we can get their partnership in these efforts, we usually have a much more successful outcome. And the truth is that in many of the countries we work in, there are not markets that the companies potentially are going to be able to participate in. So there are definitely market distortions that need to be corrected. So often there's the rich world markets that the companies are working on, and then there are the communities that we are mostly concerned with. We are not these markets. So there's often a good way to split that intellectual property question.
Yeah, we probably will have come back to that. But Peter, I know that you have been working, or your organization has been working very much in market shaping, trying to maximize the outreach that we can have with the same money, the number of drugs, to say it very bluntly, that we can give to people. Where do we stand on that? Do you feel we're making enough progress? What are the challenges? And maybe we can then lead straight into the next session, where you may wish to ask one of your co-panelists a question, or myself, if you want to. Peter.
Can I start actually by answering a completely different question? Which is prompted by a comment that Trevor made about, in some ways the more interesting SDGs for health are the ones that aren't the health SDG. And I think this is really true when you shift focus from treating diseases to trying to prevent them and trying to end the epidemics. And HIV is a really good example of this. If you look at what's happening with new infections in HIV, the biggest single number of new infections is with adolescent girls and young women. And the root causes of that are deep structural gender inequalities, sexual violence, economic disempowerment, educational disadvantage. So you go straight to the SDG on gender. That's where the answer, if we just deal with biomedical things, we've kind of lost the battle already. If I think of a different dynamic of new infections in HIV, it's key populations, marginalized, criminalized, stigmatized communities in many countries in the world, whether they be men who have sex with men, people who inject drugs, transgender, sex workers. And there, the issue is human rights. It's an issue of access to health services. These are often countries which can actually afford to diagnose and treat these people. And so again, you go to the SDG about human rights. So I think this is part of the power of the framework, is it makes you think about the interdependencies of these things. The question about market shaping and are we doing enough? I don't think, the blunt answer is we're doing a bunch of stuff. Some of it's working better than others. For example, the stuff we're doing in collaboration with Gates and Unitaid and PMI on next generation bed nets, reacting to the increasing mosquito resistance to the current generation of pyrethroid-based insecticides. That kind of stuff is working. But if I look across the whole span of what we're doing and the way we're thinking about the pipeline that we need versus the pipeline that we've got, and the way we're working with the private sector and the way we're thinking about the incentive sets, I'm afraid to say I think we're scratching the surface. Trevor, you're in this space on a broader canvas than I am, and you're an active participant. I'd be interested in what you think. I don't think we've quite got it. If I think about things like the whole MDR TB space, we've had a couple of drugs in the last 40 years. We don't really have, we know that inevitably we're going to get resistance to those. We don't really have the next generation. We have some interesting things happening in the vaccine space, but I don't think we've got a system that we can confidently say kind of works. What's your answer to that?
Absolutely agree. We're very distant. Bernhard, those goals you were talking about, the trajectories, to our expectations in 2030. So if I take just HIV, TB, malaria. So we have these projections which are not going to get to the goals in 2030, it looks like. But then, more disappointingly, we have the upside, which is that if we do everything perfectly that was done before, all the stars align, so we really do better than expected, then the best in the better than expected still doesn't get us to the goals, which means that we have to do something completely different, which is on a scale that is much vaster than the current scale. We need breakthrough innovations in each of those areas, and we're not going to get those breakthrough innovations if we don't fully have commitment from industry, from academia, on a scale that is much greater than what's going on right now.
Is that your question to Caroline?
Well, I can certainly speak to the fact that as the industry, I think, and as Pfizer, we believe that we do a good job of discovering, developing, and bringing to market medicines. Where we've engaged, I think, very productively in the most recent year and a half, maybe Trevor will correct me if I'm wrong, is the foundation around the concept of incentives, as well as the work that I think the foundation has driven around creative financing mechanisms. And we've got to get that incentive structure correct. And the reality is that I think the dialogue begins to stop because there are certain perspectives at the table that don't believe the industry should get any incentive for developing drugs that there's no market for. And I think we have to get past that to get to a more productive place. There are many, many tools in the incentive toolbox that have been around for years, but unfortunately, they've not taken root because it does require political will. It does require a deeper understanding of the complexity of drug development and how markets work. And so I think that those tools are there. It's a matter of figuring out our energy behind them, putting energy behind that, and having something that feels comfortable with the appropriate guardrails in place for any industry to advance that work. And we're not there yet, but our hope is that with good productive dialogue, we can advance that so that we can be more productive partners in this space as we want to be.
I want to push you on that because I'm looking to Trevor. We don't want to have a dialogue here, but I'll bring the others in later. I think, I want to ask you, is that an escape road that you're raising is, that we don't have the incentives? I want to ask Trevor, I think you have been thinking a lot about what could be the right incentives. Are we getting to the honest discussion that we want to achieve? I think you pick it up.
I mean, between the two of us. Look, I think we've been spending a significant amount of time, whether that's in the context of AMR, and I'm struggling with a bit of a cold, whether that's in the context of AMR or if you're looking at the traditional HIV-TB, we have a lot of work underway, both at Pfizer but also through our industry associations, to look at what incentives can make sense. And yes, some people will be at the table and say, that's what industry says, we don't really believe them. But it is in our best interest collectively as a world to address AMR. It is in our best interest to bring to market medicines that reach the patients that need them. And so I believe, whether you want to believe in the past, I think today, with brokers like Gates, with people who are trying to drive toward real data-driven decisions, we are at the table with our policymakers trying to come up with solutions that work. We're not there yet. And many people remain skeptical of that, but I think it's genuine, and I know, been investing a lot of time with the foundation alone in just these types of conversations.
Yes, Karen, I agree. I mean, some of the incentives, I think the voucher system in the US has resulted in some useful new products in the neglected diseases space. So those types of incentives, if there was something like that in Europe, would be powerful. I think we can push the companies as well a little bit harder. As much as I was talking about the lack of markets in some of the countries, regions we work in, if companies take the very long-term view, which I know many companies do, that they're going to be around for decades, then I know that companies are prepared to invest a significant amount in understanding markets and becoming familiar with populations. And it may be that sort of longer-term view that there's an investment in these countries, which ultimately are going to be the high-growth countries. Certainly it's going to be high-growth population growth, and that's going to follow with high economic growth as well. So it's an investment for the companies in their future, but it's going to take a much longer-term view than a quarterly profit view.
I think, if I may, there's a broader challenge here about the way the global health community interacts with the private sector. And here I'm not just talking about pharmaceutical companies or private health providers, but I'm talking about the vast bulk of companies of all sectors, be they retailers or manufacturers or law firms or whatever. I'm very struck by the fact that if you looked at the annual reports of the Forbes 500 companies and looked at them and said, how many of them have targets and commitments and strategies around climate change and the environment, I know, because I've had a poor research assistant doing this over the summer, that three-quarters of them will have lots of specific commitments and targets and so on around the climate change and the environment. I also know, because this was a very diligent research assistant, that outside the pharmaceutical and health provider sector, the percentage who have commitments around global health are in single digits. Somehow or other, we have got, and it almost doesn't matter whose fault it was, but somehow or other, we have failed to engage the huge amount of energy, capability, resources, infrastructure that exists in the broader private sector. And I think this is something that collectively, and of course, you may have the answer to this, but collectively, we need to think about how we do better. And I think one of the things that climate change environment community did, which I don't think we do as well, is they engage the companies they think are the problem. Whereas I think the normal reaction of the global health community is not to talk to the companies they think are the problem. And I think we need to reflect on it, because the ambition of the SDGs is so great, and we are risking falling short. We're going to need to use whatever the capabilities, the skills, the resources we can. And I think we will struggle to do it without a better engagement of the private sector more broadly, including the farmer, but more broadly than that. Do you have the answer?
No. And I was joking during lunchtime that, 2030 I'm going to be retired and just watching what all these people have done to achieve the SDGs, right? No, but I think there are several. So we're now discussing AMR, right? And what's needed, or like I think very much the discussion around global discussion around AMR. It's in a way the discussion we had with the tobacco years ago, because you need to get so many people, so many different sectors around the table and agree on something that aims for better health. And the same thing for R&D, in orphan drugs or for R&D that actually meet the diseases that affect most people. I think we are, for the SDGs, it's not for the SDGs, it's for us to envisage that people actually will have better health outcomes. We need to think of a lot of constructs, global agreements that will need to be in place. Like AMR, we need to have the food and the veterinary. We need to have the medical staff. We need to have everybody, the producers. We need to have new antibiotics because the pipeline is very, very weak. But this is a lot of things that need to be unpacked one by one. If we cannot unpack them, they will not be done. If we collectively are not able to find solutions for each of these areas with actionable solutions below, we won't get anywhere. And I think it can be done. And I always cite when people say, no, but this is, AMR is difficult, or R&D is difficult. Of course it's difficult. Tobacco was very difficult.
Yeah, thank you. It may be worth to really go a little bit into depth. I think, Trevor, what you said, that even if we do the best of what we have done so far, we won't get there. And I think, sort of a proverb comes to my mind, if the definition of stupidity is continue to do the same thing and expect a different result. What is it that we can do different? What is the disruptor that we need, the innovation that we need? And, obviously I don't expect complete answers, but, building on what Mariangela said, in each of these areas, let's pick one of those crafts where we don't get anywhere and say, what is it that we need to bring that innovation, that difference, that we can actually fundamentally change the trajectory to have a chance to achieve the SDGs? You have any ideas?
Well, Bernhard, let me just take one example, which would be in the malaria area. where we think we need some new vector control tools. And this comes to another point, which is, having been in the product development area for a long time, product development is a partnership, particularly product development in the global health space, because there are minimally 4 entities that need to be involved in what happens with the partnership. There needs to be the group that discovers the new product. There needs to be the group that would develop it. There needs to be the group that manufactures and launches it. And there needs to be the group that delivers it. So you've at least got 4 partners involved, and usually those are split up as well over here. So you can see that to get this new vector control, we have in the people over here and the people across the way at the Grand Challenges meeting, 1,000 ideas about new vector control products, and some of them are really promising. But what we lack is that at least quadruple partnership that is going to let those things be available in 2025 so they can still impact the 2030 agenda.
Caroline, maybe you want to, I've given you a hard time in the last one. So what is it that I know that you spoke about partnership. I like what you're saying is, it is a little bit moving from the MDGs in the way we work together into the SDGs, where we really work in partnership, cut across. What is it we can do to actually create these partnerships that have a joint and a shared vision of what Mariangela said, this is the health and well-being of the people?
So I want to go back to the comment about engaging climate change folks engaged the energy industry. So from my perspective, we do well discovering, developing, and bringing to market medicines. If we can sit down and figure out together how to unleash that productively, recognizing that the downside of quarterly earnings and the conversation around the role of investors, because we are a publicly traded company and we do have responsibility to those shareholders, that we move with a sense of urgency. So we have been able to really refine, and I speak broadly in this context, how you maximize the efficiency of drug development. You know this from your days in the industry. And so I think we've got that. If we can sit down and figure out then what does that incentive structure look like, or how do we explain the public-private partnership around delivery. And I'll give you one example of this that we've worked with the foundation on, and with PATH and others, which is Sienna Press. This is something you may know. It's a new innovative opportunity for us in the family planning space, but this has taken years, right? Years to bring to market. And the reality is it's not perfect yet. We spend a lot of our time on trying to figure out how each of the individual players, including Pfizer, work in country to deliver that. So I would say we have an ability, we have an efficiency, we move with urgency. Let's unleash that, but recognize we also have to speak to multiple stakeholders, including our shareholders, about this, and we have to figure out how to put that forward and gain that broader endorsement. And I can't wait till I can ask a question.
You want to ask a question? Go ahead.
So I would say that since we're talking about the skepticism of the private sector, maybe I'd ask the panelists to touch on, so there's a lot of skepticism, but what are the attributes of the companies, and I'm imagining that Trevor has some opinions on this as well, that have made a difference, that don't feel like platitudes, that feel like there's a real roll up your sleeves, we're going to figure it out. If you could sort of give us an indication of what you see either through specific examples or through broader attributes, would love to hear it.
Why don't we do a round of what are the attributes of a pharma company that we like? Mariangela.
With pleasure, thank you. I think it's maybe it's a dream. Okay, here I'm being myself in the sense that I would really like, if we could think of the industry as actually promoting health and not being disease specific. And also that the pharma industry is viewed not from the shareholders' perspective only, but that it's not equal. Dealing with health is not equal to making car parts or to selling food in the market. No, it's got a greater calling, right? And I say this because when you have a global public good, let's say like a medicine that can cure people, like hepatitis C medicines, right? And then you have an ethical imperative, that is medicines that actually have the potential to change people's life. They don't have to die because of it. And actually they have to be affordable and they have to be accessible. So, and that's the scenario. At the same time that I understand that companies need to profit and so on. But what is it that constitute a good return on investment for R&D? And that doesn't end up on the other end of the scale on an impossible price for governments or individuals to pay. So how do you bridge that? How do you make sure that you have an agreement, a construct that will actually help people that not to die from unnecessary causes, to die unnecessarily early, or to suffer when they didn't have to? And then this is more of a dream, but I think we need a kind of a global agreement on this kind of thing. To what extent, what does it constitute a good return on investment for our companies, but at the same time that you have an access measure behind it, that people will be able to address what's a true innovation, something that actually benefits people.
So
Kenny, why don't we? I have to give the word to Peter because he's sinking in his chair, and then I want to prevent him slide off.
I don't think I can beat Mariangela's answer. It was a really very, very good answer. The thing I think is that basically people build trust. What we need to do is build trust, and you build trust by working together with a common mission. And I think the more we can engage with companies who are genuinely interested and focused on particular aspects of health, and that's the way we will get to the sense of mutual understanding of what has to be true for something to be economically sustainable for a company, and what has to be done, and what kinds of things do we need to do to enable people to have better health. And I think I think too often we're stuck in kind of transactional fights about a particular drug or a particular price, rather than building the sort of longer-term relationships. And necessarily they're going to be focused on particular aspects of health or disease areas. But that's the way I think one builds longer-term trust.
Correct.
Maybe if I could, and first of all, I appreciate the candid response, but I think also what is probably deeply upsetting to those of us in the industry is that people, we have no wind at our back on this, right? That the audience maybe doesn't believe that we actually want to prevent disease. We want people to be healthy. We want the innovations that we develop in our labs to make it to the patients who need it. And it's interesting that the applause came for that with such, and that's the way it is, right? And so how are we going to move that forward so that there is more of a sense that whether it's Caroline at Pfizer or our industry association or Pfizer Germany, that when we sit down at the table that you believe us, when we say we actually want the medicines that we discover and develop to make it to those folks who need it, and that we need to navigate carefully all the stakeholders who feel they own and are a part of what we do every day at Pfizer. So I appreciate the candor, and I just wanted to say, though, I felt I would be remiss if I didn't, that every single person I've ever met at Pfizer came to work because they thought we could unleash significant benefit to the world. That was true for me, and I've served in many sectors. It's true for a lot of colleagues. You can speak to that, too, because you've worn two hats.
Well, on that front, I do think that the contribution of the companies to the NTD, neglected tropical disease effort, and the drug donations, such as the trachoma donation from Pfizer, have made a big difference. So that's been a contribution. I would say that, when we work with companies, what I like is that these companies have got tens of thousands of employees, hardworking, technical people, come to work every day and work hard. And as soon as you go down in the companies and you work with the people like we're working with on the TB initiatives, those people really are there and want to see the drugs get out. They want to, if you give them half a chance in their Google time, they'll spend all their waking hours working on some of these projects on TB and other things. So it's true, deep in the companies, you have a lot of people who are really committed to healthcare for all.
Yeah. I think this is very important. I mean, if we talk about trust and partnership, we also have to overcome what could be very simplistic dialogue. You know, here's the bad guys, here's the good guys. Truth is somewhere else. And I always say that I'm a living example of having benefited from a system that actually has brought innovation in the past. And before we throw that out, you know, we have to think very carefully. And I think it is the challenge, how can we actually improve the system? And I think many of the points you said will get there. Now, I got the sign that I have to wrap up, but I think we have another 30 minutes, right? Or 20 minutes. Is that correct? Anyway.
Can I ask Trevor a question?
Oh, you can. Okay.
Do we have time?
I think we have time, and then I want to, you know, I will ask you a question as well. Go ahead.
It was good I got mine in first then.
Exactly.
Okay, the Gates Foundation's money originally came from software, got a deep sort of focus on data and all this sort of stuff. One of the things that's really struck me since I've been in this world is not just that the data often isn't as rich or stratified or granular as you want, but actually the thing that has really struck me is just how slow it is. So malaria, for example, we are currently soon going to get the Global Malaria Report from WHO, which will tell us what was achieved in 2017. Now, malaria is a disease where the intrinsic volatility of the disease is actually really rapid. You get very strong seasonal fluctuations, variations in case numbers and so on. And I think one of the things we have to do is move to a much shorter cycle of reporting, because at the moment it's a bit like kind of flying a plane looking out the back window. We're always responding to something that happened last year. I mean, every time I talk to people at Gates, they're always obsessed with data and things. How do you look at this, and how can we move? Because it's true of all three of the diseases, is that most of the data is on an annual cycle. How can we move to an environment where we're getting much more frequent feedback on what's working, what isn't working, how can we change course, how can we scale up things that work really well? If you could solve it in the next couple of months, that would be really, really convenient.
Well, we could solve it probably in the next couple of minutes if everybody buys in over here. But, so Peter, I think that you are going against practices which have been around for many years, so there needs to be an equal opposite force to change those practices. And then you say, so this frequent data, what is it going to be used for? Now, you have your replenishment coming up next year, and maybe we can double the funding you have for malaria in that replenishment. That'd be fantastic. We know that would be great. But we know that even with double the malaria budget that you have, it is dramatically inadequate to the problem that is out there. And many groups have talked about the need to use the existing resources we have better through targeting. That means that bed nets go to those places and countries that have got the highest levels of endemic malaria. They don't go to urban and peri-urban areas and be misdirected. So we need to have a system whereby we know where outbreaks are occurring. With that, you can do the targeting, and in that way, you can maximally use the existing resources you have. So I think that once we make the motivation, why do you need the frequent data? Because it's going to be targeting, because it's going to double your money effectively without even having to go through the replenishment.
Mariangela.
I was just going to say that I You should be asking that to WHO as well.
Yeah. That's true.
Malaria is not my business, so I'm not.
Do I get to ask Bernhard? No, but it is a serious question. I mean, and I realize there's a sort of machinery and the data comes up and it gets validated and all this sort of stuff. But the reality is data that was 95% accurate or 90% accurate that is 2 months old or a month old is much, much more valuable than data that is 100% accurate and is a year old. Because, you know, I definitely know that what's going on in the countries on malaria right now bears very little resemblance to what was going on in 2017. And so our ability to target geospatially, so to have geographic targeting, and our ability to flex the amount we're putting in according to seasonality and according to surges of malaria, this would make the return on investment much, much higher, and I think would change the whole dynamic. It would make people think differently about the speed with which they have to make decisions.
Let me provoke the panel on this one. I think it's clear that better and more frequent data are, of course, better to guide decisions. But what is the information that we really need to make sure that those who have to take decisions take the right decision? Is it the data? Is it the epi stuff? Or is it something else?
I think I mean, it's very difficult to give a generic answer because you need to get into the minutiae of the decision you're trying to make. But if you take an example that Trevor had just talked about, which is improved vector control. We know that we're seeing mosquitoes being resistant to pyrethroid-based nets. We are investing in the next generation of nets. They are going to be more expensive, like 2 or 3 times as much as the current generation. So the question is, where are we going to use them, right? And what we want to do, what we will need to be able to do is understand precisely where the pockets of vector resistance are occurring, put in the new generation of nets there and only there, because we won't be able to afford to do it everywhere else. And we will also want to do it really fast. So as soon as we see them occurring, we blitz that little area with those nets, so we kill off the resistant mosquitoes as much as we can, and we may do other interventions as well, using different forms of vector control. So you can see that, you know, if you had geographically specific, frequent data, the whole way you would approach vector control would become so much more targeted and dynamic. Instead of what we do is we do these, you know, every 3 years we do a bed net campaign which rolls out hundreds of millions of bed nets in a particular country, and then when they get worn out, we do another one. It's just moving us to a completely different type of model. So, I mean, your question is a good one, which is you have to ask specifically, what are the decisions you're going to take, and what are you going to do differently that requires different data? But I can tell you, across the 3 diseases that we're involved in, I could make a compelling case for much more frequent data across all 3.
I take that. Let's move into another area where the major burden of disease currently is emerging, the non-communicable diseases. 80% of that burden is linked to behavior that people choose to take. Do you really think that in that area, I mean, 80% of young people don't have enough physical activity. Half of them are overweight in many countries. So collecting that information on a quarterly basis, will that help you to actually change?
I confess I'm not an NCD person. You know, I've struggled to climb the learning curve on infectious diseases. So, as a non-scientist and a non-clinician, I don't think there is a golden rule that says you always have to have the data on the same frequency for every single sort of decision. There are some decisions where, you know, annual data may be absolutely fine. I certainly think that with things where the stratification across different parts of society, whether it's gender or age or community or the geographic stratification makes a difference, then you need that kind of granularity. And you see, one of the things we've been pushing on very hard is to get much more gender granularity on our data, because it does make a difference, and you do different things.
Now, let me be more concrete. The point I wanted to get is that in many ways we actually do know what would need to change, but it just doesn't change, right? How can we actually create, and that very often is political choices. It's political decisions, it's leadership, it's walk the talk to introduce a change that we currently don't see. And there's many odds, like the industry wants to make money with sugar, so there's no sugar taxes. All of these things, we know that works. So what is it that we have to do to actually change that situation? Trevor.
Well, Bernhard, now that you bring up the NCDs, I think that this is a incredibly vexing problem, because now you get into systems, chronic disease, the treatment of those systems. Now you get into the objectives around universal health care and primary health care. And without investment in so this is really not, I believe, primarily in these disease SDG 3s. Now you are in agriculture, nutrition, education, and health systems, universal health care. That's, to my mind, the solution on the NCD front.
I would be remiss if I didn't mention that the industry did launch an initiative called Access Accelerated, which is a commitment to address NCDs. And there are 3 components to that, which include individual company commitments, a partnership with the World Bank and with UICC. That said, I think one of the complexities of NCDs is back to how we know some things work. We also know that a shared and common goal, which has emerged from this conversation, makes putting the assumptions about your partners aside and keep your, helps you keep your eyes on the prize. NCDs there's so many comorbid conditions, so much complexity, so many different diseases fall into that category that I think it's easy to get a little bit caught in that complexity. And I think what we have to do is to focus on what we know works and do our best to advance that with the role that we play at the table to drive that change. And I just one comment on data, because I not that I regret asking my question, but I will say that I get a little bit concerned that we get very excited about blockchain and we get very excited about technology transforming how health will change, and that's true. But I think sometimes that's a sideline to the basics, which is we know that access to clean water makes a huge difference in people's health, yet we don't have that. To your point, we know that there are structural interventions that will help people be healthier, ways we can encourage people to take better care of themselves. So how can we get back to just maybe those, what seemingly are easier things and paths to take that will get us to that prevention that we want?
Mariangela.
Yeah, I'm going to talk about not the data, but because what many times strikes me, when good is good enough to make a decision, right? And I worked for some years with the Ministry of Health in Brazil, and passed through in 7 years to 3 different ministers, and the best one was a surgeon, because surgeons have to make quick decisions. The worst one was a psychiatrist. He had to think too much about it. So it's decision making. I think for WHO is a standard setting organization, norm setting, so we need to work with the best available evidence and so on. But many times at country level, you can have a different stand. You can make decisions on intermediate results, and that's what I think helps to move some agendas. On the NCDs, first I also have a problem with the NCDs. Non-communicable and communicable, it's very old, right? Because now we have chronic and acute, right? People who live long-term with a disease that needs a different type of care, and people who are on an acute, an emergency, and they need. So HIV and hepatitis C and hypertension, they should be the same model of care. Right? And I think there's something that this dichotomy is so outdated. Now we need to start to think differently. Things that people need to live need to live a long time, they require different. And that requires also the access to medicines. And I was just on another panel today. I'm sorry some people already heard me say that today. But the access to the commodities, like for diagnostics and for the medical devices, hypertensive cuffs and medicines, it's not a given on NCDs. You know, and the older I get, the more. I used to be a pediatrician. Now I'm very partial to the older people's diseases, right? When you're saying you don't know about NCDs, you're probably already suffering from one and you don't know it yet. But I think we need to think of the elements that the whole spectrum on the NCDs that will make change. We need to make changes to bring the elements of the access not only to services, the health promotion, of course, but it's also the early diagnostics and the inadequate treatment. And here I am, the last thing I'm going to say. It's the insulin case. I think we have a case with insulin. We were talking about market shaping before. Insulin is going to be 100 years in a few years, 2 or 3 years. It's going to be 100 years old. And the global market today is controlled by 96% by 3 companies. And there are people, even in developed countries, who cannot afford insulin. And insulin is like this. If you take smaller doses, you die. You don't take it, you die. You know, so it's a life-saving commodity. So what is it that these kind of things have to come more? Those here who are the NCD people, the chronic diseases activists, you need to bring it more to the table like we are bringing right now. Let's discuss this and see how do you decrease the inequities in access to NCDs medicines.
Peter.
Sorry, I was just thinking that a lot of these things actually underscore one of the basic truths that runs through the whole SDG agenda, which is that there's an interdependence between different issues and that different institutions have to work together to get to answers. And so if I take, for example, the notion of next generation bed nets to respond to vector resistance, the need for better data and more granular. Now, the only way we can do that is by working very closely with WHO, because WHO holds the data, who has to work very, very closely with their partners in countries who generate the data. And we're going to need technological solutions, the sorts that Gates Foundation is often involved in, that enable smart collation, interpretation, utilization of that kind of data. And so it requires we certainly don't have the ability to solve that problem on our own. We have to do it with a bunch of other people. And I think that is one of the things that is powerful about, you know, the action plan that we've been working on and all the stuff we've been doing around trying to change the way we work together, that actually we can stop these problems being ones that we just whinge about every year and never change. But we can actually turn them into things where we say, okay, so now we're producing, you know, malaria data on a monthly basis, and that's normal, and we're doing it to a district level, and you know, that's the way we do things. I think we can shift the dial on some of these things.
Yes, Trevor?
I just wanted to jump in on Mariangela's point and some of the discussions around NCDs here, because I don't want us to repeat some problems with moving from MDGs to SDGs and leaving an unfinished agenda. So why do we focus then on HIV, TB, malaria? We're all watching this epidemic of NCDs, which is impacting very poor countries as much as it impacts Europe, the US, the rich world. Well, I do believe that there's an element of equity in this. One is that even those countries, wealthy countries, have not solved the public health aspects of the NCDs. They're a growing epidemic. And the solution is not just drug treatments at the end of the day once you have. Many people believe the solution is around prevention in the first instance, as of yet an unsolved problem. But you look at these countries and they do not have HIV, TB, malaria in some of them at all, or in any ways the epidemics that are occurring in the regions that we're working in, particularly in the area of sub-Saharan Africa. So there is a huge agenda, which I believe is an equity agenda, which needs to be completed before we completely diffuse away the resources in the global health community. That's not to say that there are not, mental health is not an important issue, NCDs are not an important issue, but we do have to complete our agendas over here.
All right. Now we have another 5 minutes to go, and I want to touch on one other topic. And another 5 minutes because we have actually 8 minutes, but we'll give the last round to each one of you to tell us the one thing, if you could change that with the magic wand, what it would be to get us to the SDGs. But we finished with that, so we can start to think about it. But before we get there, Peter, the budget of the World Health Organization is about the same to a budget of an average size hospital in New York City. Do we have enough money to actually do all the things? Do you have enough money to do all the things that we need to do?
The easy answer. The easy answer is no, right? And but that's an easy answer to a lot of things, is that everybody wants more money for everything. And I think most people who, not just in the global health arena, but in other arenas who have SDG objectives would probably make the same argument. So I think to be able to make the argument that we need more money, and the Global Fund for Replenishment is in 2019, and I will be making that argument, is we need to demonstrate that it's well used, that it delivers results, and also people like to know they're fighting a winnable battle, right? And certainly in the AIDS, TB, and malaria arena, we are fighting a winnable battle. I mean, the tantalizing thing is that these are epidemics that we know we can beat. But we aren't yet quite in a position to do so. We don't have quite enough resources, we haven't got quite enough innovation, and there are a whole bunch of things about the way we do things. We work with various partners and in countries and in the multilateral system, which we need to do better. But it is not an impossible task. And we also need to give people the sense of what the scale of the prize is in terms of lives, in terms of the impact on families and communities, in terms of the impact on economies and economic development. And I also think we have to be constantly ruthless with ourselves on making sure that we are squeezing out efficiencies, taking every opportunity to sort of keep focused. And there is a tension here because a lot of the SDG stuff drives you to think broadly about your mission, and yet making a compelling investment case, you often need to be extremely focused to give a compelling return on investment. But, I mean, the reality is, if political leaders want to achieve the objectives they signed up to with the SDGs, they're not going to achieve the SDG 3 objectives with the current levels of resource commitment. I think most of that incremental resource commitment is going to be domestically funded, and so it should be, because in the long run, that is the proper, sustainable way, is to have national health financing strategies, and whether it's taxpayer funded or health insurance systems or whatever, it needs to work within the economic fabric of the country. Donor assistance is clearly going to play a critical role to get us to ending the epidemics. So, short answer is not quite. No, we don't have enough money. But actually, I think people underestimate how much difference relatively small amounts of incremental money would make. So, just because we've been talking a bit about malaria. Malaria, total global spending is $3 billion a year. The Global Fund is 1.2 of that $3 billion. And I'm talking both domestic and external. I think the WHO estimates are that we would really need to spend 6 to 7 billion, and I think that's probably right. However, another 600, 900 million a year would make an enormous difference in terms of taking some of the highest burden countries and really making a big impact on them.
I think clearly being more effective, we need some more money is very important, but I want to push us collectively in the last minutes we have. The next 12 months we see replenishments of the major health funding institutions all coming. The Gates Foundation is supporting all of them. How do you decide, apparently competing mechanisms, where do you put the money? Or is there another way of actually doing business with health financing globally?
Well, Bernhard, as much as we don't see the competition, clearly funders broadly do. So we often have to make choices. I would say that there's one area where we can't make a choice. So we think that certainly both the Global Fund and Gavi are pivotal in funding vehicles in global health. And without those two vehicles, we go backwards decades. So I think everybody in the room, everybody invested in global health anyway, has to pay a lot of attention to these two replenishments. Firstly, Global Fund coming up, followed quite shortly by Gavi. Because this is a pivotal time. There's skepticism. We're facing headwinds within the political circumstances, political classes. There's pressure against internationalism in many areas. So the multilateral approaches are under stress. So if ever there was a challenge, it's in these upcoming replenishments.
Mariangela, a question to you. Aren't we in one space? Why do we actually have different replenishment mechanisms for different organizations to achieve one set of SDGs? Is that the way to go?
We cannot have one solution. We need everybody on board. No, I'm truly believe that, because as long as we are working complementary for the greater good, I think it can work. And I think right now we're getting better at this. We're not competing, but we do. The fund does things that WHO would take too long to do. So that's why it was created once upon a time. It's my last speech, right? My last talk. So I'd like to end with one line. And in the terms of what these organizations are, everybody around this room is about, because we talked a lot during this panel about the inequities in health, right? And I think this World Health Summit was focusing on SDGs, and this is a lot about inequities. And first thing about inequities in health, they are unjust, right? I think they can be prevented, right? And I think we also agree in this panel, they are actionable. We can, if we unpack them right, we can act on them and decrease them. Thank you.
Great. That gets us to the last round. What's the one thing that you would do if you could change to get us on the trajectory?
Well, I would say let the private sector at the table, not just the pharmaceutical industry, but the private sector. I think we have a lot to offer, and it's more than just money, it's expertise. And finally, one thing that we're doing is using our voice, both I am individually, but also as a company, to advocate for the important role that multilateralism plays in the world and the role that our government should play in addressing global health.
Great. And sitting at the table is not just physically, it is with respect and dialogue. That's what I want to say. Good. Trevor.
Well, I look at those 6 non-health SDGs and which would be my favorite, which would solve most of our problems. I'm not going to get into the money area now because that would be an obvious one. But I would say that the gender equity SDG would solve almost all of the global health problems. That would get rid of the neonatal infant mortality issues, and for the big 3 you work on, at least HIV and malaria would, in terms of big daily burdens, almost go away.
I have to rethink mine because Trevor just stole it. What I would like is to see a reawakening of what seems now to be a rather unfashionable notion, which is the idea of global solidarity. It seems it has a degree of awakening here, at least in this room. But when you think about the motivation that underpinned the creation of the Global Fund, it wasn't that people, activists in Europe and North America and so on, were feeling threatened by HIV elsewhere in the world. No, they went beyond thinking of their own community's interest and said, we need to mobilize for all the people in the world, and particularly the driver here was HIV, all the people in the world being affected by HIV. And that was an incredibly powerful act of sort of global solidarity that energized people across the globe and ended up creating what is an extraordinary institution, which has had incredible results. And now we tend more to frame things like health security. And I understand the reasons we talk about health security and so on, but it's a much more self-interested concept than... And so as we talk about, and I talk about it in the frame of AIDS, TB, and malaria, but we can think about this more broadly in the whole sort of SDG 3 and SDG context, is we need a little bit of that energy and that sense of solidarity. And at one level, who cares whether all the politicians feel it? Because if enough of us feel it, we'll make them follow in our direction.
Thank you very much. I think we have to come to an end, and what distinguishes a good panel is that the last statement immediately opens up to another round of discussion we would like to take forward, which we cannot do right now. But I think a number of things have been discussed here, which will be picked up in the next session, which is the presentation of the Global Action Plan on SDG 3. So which will be including the Director General of the World Health Organization. It will include a number of ministers and representatives on the political side to take this forward. And I think many of the concepts we have been discussing here will be addressed there. So please come back to what's going to be another very exciting discussion, which will be then followed at 18 hours, as you know, in a joint session between the World Health Summit and the Grand Challenges, where the Chancellor Merkel, the Prime Minister Solberg, and others will debate these matters together with Tedros, Dr. Tedros, and Bill Gates, and see how we can look into the future to solve all the problems of the SDGs. Thank you very much.